A rare, deadly disease that leaves patients in critical condition and doctors searching for answers. Knowing the signs can save a life. This is Investigating HLH, a podcast about hemophagocytic lymphohistiocytosis brought to you by Sobi Inc.
Hi, everyone. My name is Kari Magee, and I am the Thought Leader Liaison at Sobi. I'd like to welcome you back for another episode of Investigating HLH, a podcast about hemophagocytic lymphohistiocytosis sponsored by Sobi Incorporated. For this episode, Dr. Bethany Verkamp is joining us to discuss one of her new publications. Dr. Verkamp is a hematology oncology fellow at the Cancer and Blood Disease Institute at Cincinnati Children's Hospital. Dr. Verkamp conducted a retrospective chart review to understand the relationship between markers of response and pre-BMT survival after etoposide-based therapy for hemophagocytic lymphohistiocytosis. Welcome to the podcast, and thank you for joining us, Dr. Verkamp. Would you tell us just a little bit about yourself and your experience with HLH?
Yeah, of course. So I am originally from Arkansas, and that's where I went to medical school in Little Rock. I actually met my first patient with HLH during a clinical rotation during my last year of med school. I came to Cincinnati Children's for residency. I was interested in HLH, but had no idea that I was coming to the HLH Center of Excellence. But it worked out well. I was introduced to Michael Jordan during my second year of residency, and we started working on some research projects together, including the one that we're talking about today. And then I was fortunate to be able to stay at Cincinnati Children's for fellowship, and I'm now in my third year of fellowship, and I'm working in Dr. Jordan's lab on various projects focusing on both HLH and some other BMT-related complications that we're working on.
Thank you for sharing that with us, and I love that you're a Southern girl like me, being from Oklahoma, but thank you. I'm just really excited that you're here and you're going to share your insights with us. So let's just get started. Let's talk about the publication in Blood Advances titled Early Response Markers Predict Survival After Etoposide-Based Therapy of Hemophagocytic Lymphohistiocytosis. So in a previous episode, we talked about etoposide being the common first-line therapy used to treat patients with HLH. So Dr. Verkamp, if you could just give us an overview of the objective of this retrospective study and what you and your team were assessing in the patients who received etoposide treatment.
Yeah, of course. So currently the initial therapy, like you mentioned, for HLH is with etoposide and dexamethasone, and this is based off of the HLH 94 and 2004 treatment protocols. And this approach has led to a really significant improvement in outcome, but there's still a high rate of early deaths. Up to 20 to 29% of patients still died pre-BMT, so before they were able to get the curative transplant that they needed in these two studies. And a significant number of these deaths were occurring in the first couple of months after diagnosis. And most often this is due to either refractory HLH, so it's not responding to this standard therapy, or due to recurrence of active HLH after a patient had an initial response. And more recently, there's been a lot of progress with other agents that can be used for HLH therapy, but the challenge is that there's no standard definition of what refractory HLH looks like in terms of lab values or prognostic indicators. And the clinical manifestations of HLH are very widespread, and they can vary greatly from patient to patient, and even within the same patient as the disease progresses over time. And while there have been some papers that have examined the prognostic features of HLH, these papers have mostly focused on the lab values at the initial presentation or at diagnosis, and the few that did look at post-treatment lab markers looked at later time points, most often at 8 weeks, and some at 2 or 4 weeks of therapy. And also, most of these papers weren't able to include soluble IL-2 receptor or SCD25 data, which we know is an important marker in HLH. And a lot of these papers included patients who had very different treatment strategies. So our goal or our objective for this study was to look at patients who were all started on etoposide and dexamethasone-based therapy and to compare multiple lab values across time to determine the optimal parameters, their thresholds, and the best timing for early risk stratification during this initial therapy to best predict early pre-BMT mortality in patients with HLH.
Okay, thank you. That is a very good detailed background. And, it really sounds like there's a clear need for an evidence-based assessment of the treatment response for patients with HLH. There's just really no set regimen that we go through. So kind of looking at this seems like is really going to be beneficial to these other HLH treaters. So, we really appreciate that you and your colleagues are working hard and recognize this, that you're working towards this. So there are some study limitations involved with this study. This study is a retrospective chart review, so causality cannot be established. The sample was pooled from patients treated at multiple institutions with different treatments and/or response protocols. The sample size was small and missing data were imputed. So these findings should be interpreted alongside other relevant lab assessments and with the physician's own clinical judgment. Obviously, prospective controlled studies with larger sample sizes are needed to determine correlation between response markers and mortality. So we know that HLH is associated with a wide range of clinical features and lab abnormalities, and not one HLH patient really looks the same. They're also very different. So when you decided to go and do this retrospective study, you chose patients and looked through their chart. So could you tell us just a little bit about the patients whose charts were reviewed and which lab values were assessed?
Yes. So for this analysis, it involved 3 different centers: Cincinnati Children's, Arkansas Children's Hospital, and then Schneider Children's Medical Center of Israel. And we looked for patients that were treated for HLH between 2010 to 2019 at any of these 3 centers. And we ultimately identified 89 patients who met inclusion criteria. Our main inclusion criteria was at least starting with upfront therapy using etoposide and dexamethasone. So one key thing to know is that we did not include any patient that was too sick to receive this etoposide therapy and potentially died before they were able to receive it. So we are missing that piece of the HLH patient population. And then we also excluded any patient who had an undiagnosed malignancy that was triggering their HLH. We did include MAS, or macrophage activation syndrome, which is referring to patients with an underlying rheumatologic disorder that is causing their HLH. I believe 10% of the patients in the study had that diagnosis. Most patients had a genetic diagnosis of HLH. 49% had known genetic defects that are associated with HLH, and then another 17% had kind of indeterminate or ambiguous genetic findings, meaning they had a mutation in a gene that we know is associated with HLH, but maybe their mutation is one that hasn't been classified as pathogenic yet, but we suspect it was the contributing factor. So for our review, we assessed 14 lab values, which included soluble IL-2 receptor, or SCD25, which is a marker of T-cell activation. We also assessed ferritin, hemoglobin, platelet count, the absolute neutrophil, lymphocyte, and monocyte counts, creatinine, blood urea nitrogen, or BUN, fibrinogen, alanine transaminase, or ALT, the total bilirubin, lactate dehydrogenase, or LDH, and triglyceride levels. We looked at each of these values at baseline or pre-treatment, and then at multiple time points during therapy. We ultimately looked at approximately 2 time points per week up to therapy day 100. But the majority of our analysis focused on the first 21 days of treatments, since we really wanted to capture the patients at high risk of that early mortality. For each lab marker, we also looked at their change or improvement from baseline at each time point. We did this by taking the value at the specific day and subtracted the baseline value, and then divided by the baseline value for that lab marker. So similar to looking at percent change. The primary endpoint for our analysis was survival to bone marrow transplant, or survival for 1 year if no bone marrow transplant was pursued.
So again, this was an extensive look into this data, and it really hasn't been looked at before. What results did you and your team start to see when you were really starting to analyze that data?
So overall, we found that early response to therapy was a more reliable predictor of pre-BMT mortality risk compared to the initial disease severity at onset. But again, one thing to note is the patients who died before starting etoposide weren't eligible for inclusion in our specific study. With this, we were able to identify specifically that treatment day 7 was the strongest time point in predicting pre-BMT mortality. Day 14, or after 2 weeks of therapy, did have some significant markers that were predictive of pre-BMT mortality, but these were not as strong as the day 7 markers. For those day 7 markers, there were 5 specific labs that were predictive of early mortality. These included the absolute value of soluble IL-2 receptor, change from baseline, the platelet count, the BUN, and then the absolute lymphocyte count, or ALC. In terms of thresholds, we identified that soluble CD25 levels above around 17,000, or improving by less than 25% from that baseline value, was a strong predictor of pre-BMT mortality. For platelets, this was below 25. For the absolute lymphocyte, below 0.35 or 350. And then for BUN, a level of 20 or above at day 7 were all unfavorable ranges that were associated with the higher risk of mortality. So these 5 prognostic markers all carried their own individual risk, but having multiple unfavorable markers had an additive effect and led to an even higher risk of pre-BMT mortality. Our data analysis showed that having 3 or more of these markers in the unfavorable range was highly associated with early mortality. And then looking at the individual markers, soluble CD25, and especially its improvement from baseline, was the strongest predictor, which is a marker that most people are universally checking at diagnosis, but I don't think it's as common to monitor it throughout therapy at all centers, and it's something that we think is really important to really use in your treatment response assessment.
So, Dr. Verkamp, it sounds like your research has uncovered the importance regarding monitoring patients on conventional HLH therapy. Looking at early evaluation and serial monitoring may help assess the need to potentially modify the treatment strategy. It seems like it could be extremely helpful for doctors to have information on a few of those key measures that they can monitor early in the treatment process just to help guide them in their decision-making. So of the 4 labs that you found to be the most significant, the soluble CD25, platelet count, absolute lymphocyte count, and blood urea nitrogen, are there any general strategies that you'd recommend for physicians when conducting these tests?
Yeah, so I think that this research can provide some key insights that may help physicians who are treating patients with HLH. We know that these patients are often very sick and can have a wide spectrum of disease. And while it's important to monitor all the relevant labs for an individual patient, having a few key measures to monitor as an indicator for HLH treatment response can be valuable. I think the most important part of our findings is that day 7 was a stronger predictor of pre-BMT mortality than the later time points. Of the 89 patients included in our study, 28 patients in total received some form of salvage or reintensification therapy within the first 100 days of treatment, but the median time to this therapy escalation was day 35 for all patients. When we compared the timing to this salvage therapy or therapy escalation between the group of patients who died prior to transplant to those who survived, the timing of this escalation was actually similar between the 2 groups. This analysis suggests that salvage therapy should be considered earlier for patients not showing an adequate response, or for those providers who don't often treat HLH. These are also good indicators of patients in whom early consultation with a center that sees HLH regularly could be helpful. And of course, response should be continually assessed after day 7. And we think it's really important to include soluble CD25 and its improvement from baseline at these other time points to better assess therapy response.
Dr. Verkamp, thank you so much for coming on the podcast today and just taking your time and sharing your experience with us and the knowledge that you've learned from all of the research. I think that your findings are going to be so valuable for our physicians who are navigating the HLH treatment process and looking for additional assistance and guidance. So thank you so much again. So one question I have for you is, if our listeners want to learn more about this publication, where can they find it?
Thank you again for inviting us to talk about this paper today. It's been a really good opportunity to discuss our project, and hopefully we'll lead listeners to read our paper. The link is provided in the show notes, or you can find the full paper in the Blood Advances Journal, which is on American Society of Hematology's website. We really hope that this paper is just the beginning in establishing response markers for HLH patients. And, as you mentioned earlier, the study was retrospective, which leads to several limitations. And ideally, we could collect similar data in a prospective nature in patients who are receiving similar therapy to not only validate these day 7 markers, but to hopefully get a standardized response criteria that could be used throughout therapy. I also think it would be interesting to evaluate in more detail how treatment adjustments in response to these unfavorable day 7 markers change the clinical picture of these patients. We know that they can receive treatment for a considerable amount of time and that their condition can rapidly change. So I think it would be great to learn more about the effects of different response adaptive therapeutic strategies and hopefully uncover a more standardized approach to management that can continue improving patient outcomes.
That is really exciting. And I really thank you for coming on today, and thank you for all the work that you and your colleagues have done and are doing for the HLH community. So thank you.
Awesome. Thank you. This was great.
Thanks to all of you who are watching and listening. If you enjoy the content of this episode, please make sure that you subscribe so you won't miss any future episodes, and share it with your friends. That's all for now. Again, I'm Kari Magee, and thanks for listening.